I would request all the audience to switch off their microphone, switch off the audio, please. Um, it is already a minute past 3, so let us start. Before we start, let me thank Professor Ashok Kumar to have agreed to give this webinar. Let me briefly introduce Professor Kumar. Professor Ashok Kumar is a Rajiva and Sangeeta Lahiri Chair Professor of Bioengineering at the Department of Biological Sciences and Bioengineering, IIT Kanpur, and currently holds the head of the department position at the Center for Environmental Science and Engineering. In his career span, he has been affiliated with several universities and organizations. To name a few: Aalto University, Finland; Lund University, Sweden, as a visiting professor; executive board member of the Asian Federation of Biotechnology; expert committee member of several funding agencies in biomedical sciences. He is serving as the editorial board members of several international and national biological and biotechnological journals. On the research front, which is the most impressive one, nonetheless, more impressive one, some of his significant achievements in regenerative medicine have been designing functional biomaterials and therapeutic approaches for critical defect healing of bone, liver, diabetic wounds, peripheral nerve, and developing artificial liver support bioreactor, which are at the preclinical and clinical evaluation stages. Congratulations. He has published more than 200 peer-reviewed research articles in international journals, along with several book chapters and patents. He has successfully transferred several of his patented technologies to companies for clinical translation and commercialization. He has been honored with several fellowships and awards. A few of them are Lalit Mohan Kapur Chair, Tata Innovation Fellowship Award, Madhavrao Sindhia Memorial Award, Brain Pool Fellowship Award, and JSPS Fellowship, and more. With this brief bio sketch of a illustrious scientific career of Professor Kumar, I would like to invite him to deliver this present webinar.
Thank you so much for your kind words, and thank you also for inviting me to this interesting webinar. Actually, in fact, the area particularly you have been now talking about, so the webinar actually is very close to my heart. I have been working actually in this more on the applied side. I understand I take several of the discussions with you, even for my own understanding actually from the basic point of view. But we connect those dots from the application angle actually. So thanks all who are there for attending this. So I will try to share my slides.
Yeah, we can see.
Is it visible?
Yeah, it is visible.
Yeah. So I have tried to just keep a sort of very broad title like this, but that is basically what my focus in bone particular area is: advanced strategies in bone healing and regeneration. So associated with Biological Science and Bioengineering Department, Mehta Family Center for Engineering and Science, and Center for Environmental Science and Engineering at IIT Kanpur. So I joined basically in IIT Kanpur 2004. In fact, that was just the beginning of our department at IIT Kanpur. Actually, 2001, what we call it shortly BSB department came up. So, but then the applied part, that means the bioengineering part, actually basically started in 2004 when me and Professor Dharendra, some of you must be knowing him, joined almost together. And we started with this area of bioengineering, but now in last more than, we total the department is there now for 20 years actually, but in this domain for 18 years. Many other colleagues have now joined actually the bioengineering domain, which has given us strength to the area. So what I would like to talk now during this maybe 40 minutes or a little more actually is what basically is the bone point of view from the regenerative medicine. So if there are critical conditions actually for the bone, that means the bone injuries which cannot heal on its own, what is the present scenario and what internationally the groups are looking at actually, and then what we are doing here actually on this area actually. If we look at the bone, typically the its structure and also actually the remodeling actually, that's the hemostasis. It has something actually a sort of unique type of one can say actually an architecture which has really helped actually the regenerative medicine people. That is one of aspects actually why bone regeneration as compared to maybe other type of tissues has become more successful actually because it has actually taken up clinic very fast actually, and majority of bone materials are there actually for the regenerative medicine point of view. So the obvious reason has been the anatomical structure actually of the bone. I will just try to see if I can. Okay, so if you look into the bone anatomy, actually, that you have the hard part, actually, which is cortical bone, which is the strongest part actually, in the bone, has few pores, which are less than 100 micron size, actually, whereas the cancellous trabecular part is more porous actually, and a bit weaker actually in the mechanical property actually, and has more porous structure actually, that's between 50 and 500 micron in that actually. That composition and architecture provides the unique mechanical properties actually. So, but as we all understand, actually, bone does have a sort of remodeling. Typically, actually, it has three phases. That is, you have actually a resorption, then you have a reversal actually, and then you have a formation actually. So, which is a very natural process actually in the bone. But it has basically, very much helped, people like us actually who are looking actually how to design actually the materials, which can exactly mimic actually how the natural bone is healing is taking place. Actually. If you look into, the resorption part, actually, you will see actually that the bone, which is older bone, you call it in that sense actually, or the bone which has mineralized more, you get resorbed actually by the osteoclasts actually, which are coming actually from the hematopoietic stem cells. So then you layer a sort of normal blood cells, actually monocytes, actually on the bone surface. Then you have actually from mesenchymal stem cells, actually you have the pre-osteoblasts, which can differentiate into the osteoblasts and generate basically bone matrix, actually, and that can be mineralized finally actually by the osteoblasts, actually. So that's all maybe bone biology people actually typically understand this. But I think in the last 5 to 6 years, I should tell you, or maybe a little bit more time actually, applied people, people working in the regenerative medicine actually has taken advantage of this concept actually very well, and have tried to see actually if this bone hemostasis model can be applied for regenerative medicine actually. I think that is what majorly has given a sort of major success for bone regeneration actually, because people have understood it very well. Actually. So if you will look into the bone losses and the way of healing actually they have it. So typically you have the bone injuries, which can be because of the trauma, which can be casualty injuries, surgical complication, or if you look into the bone disease conditions actually, which can be infections, major complication, tumors or congenital disorders actually. So they need all interventions actually. So these are not typically what one can presume actually that they can heal on its own actually. But before I go into that actually, what are the interventions actually? But of course there are majority of actually bone conditions actually fractures which the body takes care of on its own. So what is the difference of that vis-a-vis actually when you need to have something actually to be having the external intervention actually. So if I look at the natural bone healing, we call it as a subcritical defect actually. So you get the bone marrow involved, you get the cortical bone involved actually, cancellous as well, and the top layer actually, which is called as periosteum actually. So you have the initial phase, and this is all I'm saying actually as an anabolic phase, that in the beginning, from 0 to 5 days, you will have majorly the inflammation part actually. That is hematoma actually is generated actually in this part. you recruit basically the cells, blood cells, and they just have actually the conditions which you see in the beginning part, and you can in fact actually observe that also, because you will see these cells invading that part immediately. But then after that, you will see this anabolic part increasing. Actually, that means you have now mineralization happening. So you get a soft callus formation. Actually, chondrocytes and osteoblasts are getting differentiated from stem cells. And then you move into the fibrous tissue. Actually, then you get more these type of cells actually, which hardens this bone. And at the same time, catabolic events actually start coming in at that point. Actually, we are talking about a timeline of 10 to 15 days in that phase. You will see actually the catabolic phase coming in actually. Then this continues until 3 weeks actually, where the hard callus inside is developed, and then finally about 35 days you see actually a remodeling happens actually. But this whole what I have been trying to explain here is what the bone does on its own in a normal situation actually. You don't need to have any type of intervention actually. So that means if it's a subcritical type of problem actually. But having said that, even if it needs a sort of intervention actually from outside, the process follows the same. Okay, so there's nothing new actually one has to do it actually. You may have actually to incorporate something which may have lost actually, because if it is a critical defect actually where the body cannot take on its own actually, in that case you may have to substitute actually those parts. So what before I go to that part actually, what is basically desired, but what is right now actually being seen from the critical bone injury point of view actually, and what are the available clinical therapies actually. We still have autograft as the gold standard. So then it is followed by allografts actually. I will come to that actually, what are these different type of approaches. Then you have actually what is synthetic calcium materials, and then you have polymer cements actually. If I look into that actually, autografts actually, you can take the autograft actually, maybe you have a iliac crust, you take a part of bone from that and you crush it and just fill the gap actually, which on its own cannot be filled actually. Fill that void actually. Let us say in the case of osteosarcoma, or actually in a major sort of where the bone loss is there actually, some infections. So you just simply fill it in that bone actually from the same person actually. But then you have actually also the allografts actually, where you have demineralized bone matrix actually from other people, other patients actually in that case. You have also actually synthetic calcium materials actually, which is which will definitely come to that part actually, because that is what actually is being now taken over actually on these autografts and allografts actually for several reasons actually, because you have more flexibility actually. But these have been becoming more and more common now, like tricalcium phosphate, hydroxyapatite actually, or terracalcium phosphate collagen, which are the companies which are mentioned here like Zimmer and all. Or you have the bone xenografts coming from other species, or you have polymer based like methacrylate acid, and you have here polymethyl methacrylate, polyhydroxyethyl methacrylate actually. These were the first generation of bone substitutes or bone grafts actually, but which were more polymer based actually. So, but this is generally actually what at the moment the approaches are. Of course, these approaches are working, no problem on that actually, but they have also actually some limitations actually. I'm just describing a few of them. Of course, autograft, allograft have the limitation actually. Autograft has donor site morbidity. Allografts have the possibilities of disease transmission, graft rejection actually, and limitation of polymer cements, which even some Indian companies are basically making these polymer cements in India. These are only available actually. So they are inflammatory, they generate inflammatory reaction actually. They have exothermic setting leading to tissue necrosis. So polymer cements in some cases are still being used, but more or less actually, in normal situations, these are being avoided because of these limitations actually, which I have mentioned here. So considering this background, actually, I gave a small background actually, that what is the need actually? What are maybe the people in this area, regenerative medicine people, even the companies who are developing such type of materials actually, or even medical personnel actually who are working on these, what are they looking for actually, and what should be basically the criteria actually for such type of bone substitutes. So I have just tried to summarize that here. So of course, there are three major pillars for that. Okay, I just first mention it here in a very simplified manner, actually. So they have to be osteoconductive, actually, whatever we use. That means if not just inducing actually the cell formation, actually, or maybe the proliferation of the cell, actually, but at least they are able to grow the cells. It should not be rejecting the cells, actually. So that should be one property definitely actually of these materials. Osteoinductive growth factors, actually. So it's very hard that a synthetic material on its own can be osteoinductive, actually. But yes, of course, you can have some plant-derived materials, actually. They may have some possibility of having some sort of osteoinductive capacity, actually. But most of other synthetic materials, actually, which are polymer-based, or maybe you have actually ceramic-based materials, they are not on their own osteoinductive. So you need to have actually some growth factors. So then you need to have actually osteoprogenitor cells, actually the stem cells. Good part related to bone regeneration is that typically you don't need to supply the cells from outside, because any defect which may happen actually in the skeletal system, maybe except actually the cranial part, you have enough of cells actually coming, from the bone marrow. So typically this component which I have mentioned here is not extremely essential actually to be used as whole cells. But yes, you can basically have some components actually from these cells, actually like some vesicles, maybe some proteins from that. They may aid actually, or they may give a better sort of response actually for overall regeneration capacity actually. So considering these three, needs actually which can develop a sort of proper bone material, actually you have biomaterials actually that should be polymers, ceramics, biocomposites actually. So that is filling this requirement actually, which I said about the matrix point of view actually. Then related to the bioactive factors, actually you can use obviously BMPs. You can use fibroblast growth factors, you can use vascular endothelial growth factors, actually, or you can use parathyroid hormones as well, actually. But generally, in very, very selective situations, actually, you may need to use that. Actually, you have also have a lot of more vascular structure. Actually, in that case, maybe you want to develop periosteum. If it is lost, you may use, in that case, actually, such type of growth factors. But BMP, yes, BMP is something actually which is being commonly used, actually, and particularly actually with the regenerative medicine approach. The concentration of BMPs actually can be decreased as less as possible, because there has also been some concerns related to the higher concentrations of the BMPs actually. But on the other hand, actually, you have bisphosphonates actually which are anti-catabolic in nature actually, or you have the antibodies like dinsumabab actually. So like those type of are the growth factors which generally are being used for that. Cells, these can be primary cells or these can be MSCs actually. This is how everybody looks to design a material actually in this manner, that you have actually these properties, then you choose the different type of components actually and use them for that. So what different, I just say the strategy from the tissue engineering point of view actually, but beyond tissue engineering, obviously it is not just limited tissue engineering, but beyond that actually, what are the approaches for critical bone healing actually? So there are bone fillers and substitutes. So those bone fillers or the substitutes, actually, those can be resorbable or those can be non-resorbable. Actually, it means actually they can degrade or they cannot degrade. If it is a polymer base, like I said, polymethyl methacrylate, it cannot be resorbable. But if you have actually, something ceramic based, actually, hydroxyapatite ceramic based, actually, tricalcium phosphate, they can resorb. Then you have bone supports, actually, which this I am telling in totality. It is not just only actually from the regeneration point of view, actually, but what is needed for bone healing. That means even prosthesis, even maybe the metallic implants, actually, like bone supports. They can be polymeric implants or they can be metallic implants, actually. But metallic implants, as we all know, are like titanium rods, titanium pins, titanium plates. So these are all being used actually as supports. Or you may have now, which is coming up actually for the orthopedic applications, some degradable actually metallic implants, like magnesium-based implants. They have still not come in market actually, but they are all at a clinical, trial levels, actually, all of them. Then comes the mode of delivery. It can be oral delivery, it can be systemic delivery, or it can be the local delivery. Obviously, with materials, with nanoparticles, you can have local delivery as preferred. Bioactive molecules, as I mentioned already in the previous slide, you can have anabolic agents, anti-catabolic agents, or you can have cell-derived some secretromes like vesicles, exosomes, all. So then you have also actually specific conditions, actually, as I said, like periosteum development. Actually, that in that case, actually, you may have guided bone regeneration, which can be induced by membrane technique, periosteum specific cell sheet engineering. One of the most, you can say, interesting area which is coming up, actually, which is correlating the tissue engineering of bone, but along with other type of tissues or other organs, actually, which is interface of tissue with other, bone tissue with other tissues, like, for example, bone and marrow. Take an example of spinal cord. It's a typical example, actually, where you have to take care of both marrow and the bone. Bone and skin. Take an example of diabetic mellitus, actually, and in that case, when it comes to the osteomyelitis, actually, along with you have actually diabetic foot ulcer, then you have to take care of both bone part and skin part. Actually, osteoarthritis, actually, which is osteochondral defect. In that case, actually, in that case also you have cartilage and bone. And also in the case of, for example, bone and liver, you have an interface between bone and liver. Actually, if there is a chronic liver disease, it can lead to osteoporosis, actually, and vice versa. Actually, can be effect, actually. But these are interfaces, actually, in tissue engineering of bone, which are being looked at, actually, with the other organs as well. So I just give a sort of interest to some, actually, it's a general, actually, I talk about this, actually. What is basically the market or recent trend, actually, of these grafts? As I said, autografts and allografts still are considered to be the preference in all this, actually, but synthetic grafts are now taking over to this, actually. So as you see, actually, in this circle here, so you have the synthetic grafts like about 30%, actually, which is matching to the autografts and allografts as of now. But this scenario is going to change completely, actually, in next 10 years. But very interesting phenomena, actually, of management of, actually, these bone defects. It's majorly, actually, the first year which becomes a very critical, actually, of any disease condition, typically of osteoporosis. And because of the osteoporosis, actually, if some fractures are generated, then the management, actually, becomes time dependent. Other than, actually, if you have other conditions like infection or maybe, even some fractures and all, they are much quicker, actually. You may not have to actually stay for that. But osteoporosis is a longer duration, actually. But any type of condition generated by osteoporosis, management becomes basically the, first year, so, cost point of view, actually. So among all these fractures, actually, and particularly which is with the osteoporosis, hip fracture becomes, with respect to the cost, it incurs 56% of the total cost of the fractures. That's only the hip fractures, actually. And hip fractures, as compared to the other fractures, actually, it is 1/5 of the total fractures, actually. So that means the hip fracture becomes, actually, the major concern in dealing and managing basically the conditions related to the osteoporosis, actually. So the bone graft substitute market, actually, as of 2019 is 3.18 billion US dollar, which is projected to be 3.93 by 2027, with an annual growth rate of 5.1, which is considered to be very high. But in some of the conditions, actually, it may be much more than 5.1, actually. But if I look into the distribution globally, America, Europe, and Asia Pacific, actually, prosthetic and orthopedic market, actually, more or less is at the same level. Let us not go, actually, from the population point of view, actually, but if you just see the region point of view, actually, of course, population point of view, we still can consider, actually, Asia Pacific has lesser than as compared, actually, what the North America or Europe, actually, is in this area, actually. This also has a growth rate of total, actually, in all the types of prosthetics and orthopedic market, 4.8 annually in that direction. But among all of these, metal implants is on the highest. Metal implant actually is just vertically rising. It's 9.4%. If you see at the market as of 2019, it is 11.2 US dollar billions of US dollar. 11.2 and it is going to be projected as 17.6. The driving factors for all this is why actually this conditions is generating is rising geriatric and obese population, increasing number of road accidents and trauma, and rising demands of minimally invasive. Nobody wants to have surgeries, so you need to have something which can be minimally invasive, at least if not completely non-invasive, but minimally invasive. But of course, there are approaches like bone substitutes are used minimally invasive. They have increased the market, and also these materials have come up more larger in that context. Let me go a little bit one slide in this. Then I move what we are doing in this direction. But if you go now disease-wise, in orthopedic conditions, disease-wise, osteoporosis is on the highest. So about 8.9 million fractures happen annually globally. That means there are every 3 seconds there's a fracture. Okay, by 2050 it's projected to be 21.3 million hip fractures each year globally. Okay, what is the scenario of India? Still a little bit better because as compared to maybe West, maybe Europe particularly, and US also, you have a relatively bad, but it also can be we may not have a complete statistics here but whatever the availability I had I could collect it from that. We have 600,000 per year by 2020, in 2020, which is going to rise to 1 million by 2050. I believe it will be very high than that. It is a prediction only, but I think it will be much more than what we are talking about here, because osteoporotic situations are rising. Very interesting phenomena. I think the CDRI, many people are interested in this. They are also aware about what is basically a difference of the gender in that. So if you look into the people aged above 50, okay, you have 4.2 million men osteoporotic, while you have 15.8 million women osteoporotic above the age of 50. This is going to increase dramatically. If you look at this situation for men aged 15 years is going to be between that estimate life risk of hip fracture. So this is the overall the estimation statistics of the osteoporosis. But how many of them have the risk of getting a hip fracture, which is most critical? I can think there can be other fractures, but they are still milder than the hip fracture, because hip fracture continues; it doesn't stop. Okay, if we look into that type of situation, hip fracture among this population, among women and men, we have above 50 years, you can rise from 6.1 to 13.7, have the chances of getting hip fractures, whereas this rate is higher in the women. It's 9.8 to 22.8%, which is considered to be very high. That means every person out of 5% in the women can have hip fractures, okay, which can increase much more. So this is rising with the market. I am not going to go into these numbers, but of course, again, this market is going to be high. So after the osteoporosis, what is the other leading problem from the bone point of view? It is the infections. So though these infection numbers seems to single digit, but these are continuous and they remain for a long period of time, then that becomes a sort of very critical condition. These are typically in when you have hip arthroplasty or when you have knee arthroplasty. But it can be also simply open surgeries. You can have osteomyelitis. Of course, you have also bone tuberculosis, which becomes much more complicated in that. Then the third one, it is more dominated in the West. That is what you have the osteosarcoma, where you have bone cancer. But typically in that situation is that what is the survival rate of someone who gets a bone cancer? It is 42% actually who may be able to survive for 5 years, actually, irrespective of their age group, actually, whether they are below 40 years or they are above 40 years. If they are above 40 years, actually, the incidence actually is just 25%, actually, may survive for 5 years. If it is below 40 years, this is higher, but on an average, 42% actually is predicted to be actually the survival rate actually of patients with the osteosarcoma, bone osteosarcoma. But the things are changing. Even the prediction actually may look bleak actually in that scenario, but this is changing because of actually many situations becoming available now actually for osteosarcoma conditions actually, which was not possible earlier actually, because if you have an osteosarcoma condition, you lose the bone. Either you lose the limb or the part of the bone. Or if it is separating actually, because it is quicker separating, okay, metastasis happens quite fast actually in the bone cancer conditions actually. So what we are doing actually in bone regeneration, let me come actually to, I hope I try to, make sort of base, why do we all people who are working in bone regeneration actually, what is the need and what is the demand in that actually, and what can be done actually in that actually, and what is the approach. So what we have been in this area doing for last 10 years at IIT Kanpur, we have been looking into the 4 aspects actually. I will just broadly mention those. We have designed actually, nano cement with bioactive molecules. We have also used this as carrier active for antibiotic active and other drug molecules. We have been working actually in metal-based bone supports, majorly which are degradable, bioresorbable metal-based bone supports actually. And then we have also looked into the guided tissue engineering actually. So, if I briefly say actually in case of nano cement used with the bioactive molecules, we are looking into the cranial bone regeneration. We are that's when you have simply the bone cement as such. I will explain the slides actually what I meant by bone cements and what I mean actually when I say composites actually. So, but we make the composites actually, and we have used it for rabbit bone defects actually, and then used it for majorly actually some tibia sort of condition, bone defect actually, or cranial type of condition actually. Then we have also used it actually biphasic calcium phosphate actually, and use it with the BMP and bisphosphonates for osteoporotic hip fractures. Actually, the conditions which I mentioned, the disease conditions actually which I mentioned in the previous slide, we have majorly looked into those, as these are the major, one can say actually, where the requirement of the treatment and regeneration possibilities are high, and they are a need actually for something which is advanced in this area. We have looked into that. Antibiotic delivery, though osteomyelitis has been our interest actually, but we are majorly now focusing on tuberculosis, bone tuberculosis. That's why we are delivering actually these antibiotics actually with the bone cement materials. Then we talk about metal-based active, which is magnesium-based active, and we have also developed these in-house. And what are the limitations of developing these magnesium-based active, why they have not come into the market? We have tried to address into those. And then the last one actually is majorly how the periosteum active, which is a neglected part of bone. We don't talk about when we have actually to have a sort of bone regeneration. We don't talk so much about the periosteum actually. Even if somebody searches on the papers related to the periosteum regeneration, you will hardly find any research paper actually. But of course, basic work, a lot of work has been done in that, but not so much related to the applied work. But we have been focusing in this area for the last 5-6 years actually, how periosteum actually. See, it is generally said actually, bone saves the body and periosteum saves the bone. This is how normally is felt. And periosteum has to be very healthy actually, because it is the lifeline for the bone. That's what majorly is. If you have a major type of fracture, a major type of loss of bone, and periosteum does not get generated, you will have actually fragility factors, fractures in that case actually. So periosteum is not generated in that case. So let me start with the first example actually, which we started some time back. Actually, we, as I said, we developed the in-house calcium sulfate, actually, which is hemihydrated, and nanohydroxyapatite. So these are the two materials. Actually, if you mix them in 60 is to 40, 60 calcium sulfate hemihydrate and 40 nanohydroxyapatite with amount of 600 microliter per gram of the mixture of this material, actually with water, simply. You develop a paste, okay, and this paste is exactly like a toothpaste, and it can be just filled in the voids, and as it gets filled into the voids, it can get in 15 minutes like a cement. Okay, that is why actually I am using the word bone cement. So it is because of this, actually, because it becomes a cement, but actually it is calcium sulfate and nanohydroxyapatite actually. So previously calcium phosphate was used actually, but calcium phosphate and nanohydroxyapatite or hydroxyapatite actually you can again get the same type of material as cement, but then calcium phosphate is not water soluble actually, then bone growth was difficult in these type of materials actually. But lately, just in last people have been working in this area has designed actually this material as calcium sulfate, which is water soluble actually. So this the same image which you will see actually after it gets a cement like this, but it can be injectable as you can see here in this picture. We have seen that it is osteoconductive. We have been able actually to grow both SOS cells actually or pre-osteoblasts actually here, and you will see both by the stem actually or by the fluorescence here. Then I'm immediately coming actually that we took a sort of rat model and then have just simply a cranial defect in that in 12 weeks actually, when we just have an empty cranial defect. So it's about 8 size, which is considered to be critical in the rat. This is the circular part what I'm showing actually, which is the defect. Then if you fill it only with the cement, then you just simply put this at that defect site. But if you put it with cement and Zade is bisphosphonate, which is anti-catabolic agent. Then you have more filling here of the bone. But if you use BMP, which is anabolic, and Zade, you have almost complete recovery of the bone of this defect area. It is also been shown actually by the micro-CT analysis, what you can see it here. But then you can also see have a sort of quantified data here actually by bone volume mineralization data. Actually, in the case of when you have cement, but along with the bioactive material, which we are considering here as bisphosphonate anti-catabolic agent and BMP anabolic agent, actually, they have yielded actually the best optimum results actually in 12 weeks. Cranial defects are complex to repair completely. So, but with these interventions, actually, where you add such type of bioactive molecules, it is possible actually to completely regenerate actually, even the cranial defects. Actually, in this case, no cell was added, even if you have a limited supply of the cells in the cranial part. But still, actually, at the edges of the cranial part, actually, the cells may migrate still past. Actually, in that case. This is just the Algerian red staining to show whether we have the calcium nodules formation. You can see the maximum in the last group, which is with the BMP and Zade. And if you take the Masson trichrome active, which gives you the collagen fibrils also, it's again showing actually the one with the bioactive molecules can have the better outcome actually. So nanohydroxyapatite imparts enhanced osteoconductivity. That means it can be able to grow the cells. To nanocement, it can act as a potent carrier of bioactive molecules, can co-deliver BMP and Zade via nanocement, has synergistic effect, achieving rapid bone formation. Actually, this was I can say that why I put this, even if it is a little bit older, I can say research in my lab. I thought actually I just give you the genesis, how we started actually with this work, and then how obviously actually we move ahead. See, now considering that actually it is possible to have actually this approach, but when you have to finally come basically to the clinic, what is a major need is that actually for both two reasons actually, for medical application point of view, second for manufacturing point of view actually, this approach is still manual. you have to go actually to something which we call as additive manufacturing actually. Will that be possible actually to go actually into a very, very sort of, which is anatomically, structurally, architecturally very difficult, positions actually to fill up. So that means you have to go into the printing part actually. So we looked into that. So what typically you do by the printing actually, here again, I am taking a sort of, whatever the damage has happened actually, like for example, in the skull. So you take a CT scan, make a CAD design, print the scaffold. Good part is that you have actually the calcium derived inks, you have hydroxyapatite. We develop these in-house ourselves and make actually the scaffolds out of that. Actually make it a sort of honeycomb type of structures actually with that. But structure of the design and maybe the shape can be completely tuned actually by this CAD design. Actually you can make it the thickness wise, shape wise, exactly mimicking actually the individual patient actually. It's a more personalized type of graft constructing actually. So you have finally a sort of, as I said, honeycomb type of structure here, but in any type of shape. You can seed it with the cells if needed, but as I said, it is not necessary to seed it with the cells actually. But if it is seeded with the cells actually, maybe the efficacy becomes higher in that case actually. You may have to sometimes take the cells from the patient. Bone marrow is easy to take out actually. Just dump the bone marrow directly onto this, grow the cells in the bioreactor and implant it back. This is a general approach. Of course, there can be several variations actually in the printing part, but this is not what we call as bioprinting. It is simply 3D printed. So bone typically will not be used as 3D bioprinting, but it will be 3D printed in that because the materials are like such which may have a different type of synthetic fabrication conditions, like, which may not be easy actually with the printing part. So we took a very classical example actually. It was very much tedious job to do with this actually, but we developed a resin which is PTMC, polytrimethyl ethylene carbonate, which is 60%, and it's also having a photo cross linker put on that resin. You can get this synthetically, you can get it commercially available, but then you have to put a sort of photo synthesizer here, actually coupling on that. Then you have the hydroxyapatite in-house, or you have tricalcium phosphate actually. You mix both the components actually, and then do stereolithography. By that, you can just construct the scaffolds, what I am showing here, honeycomb type of scaffolds. We use that in tibia defect and cranial defect in the rat model. We added, in both of them, we added BMP and ZA. We kept this tibia defect for 60 days, and we kept for cranial defect for 120 days. That's the duration typically you may need to have actually. 4 months, 2 months, I can say actually is the shortest period. That can be only possible actually if you are using bioactive molecules actually. Otherwise, it takes longer than that. But cranial may take a longer because it's a large portion of the bone actually to just come back. So you may take a longer time in that 120 days in there. So the outcome point of view, actually, I am not discussing all the groups actually. Obviously, when you carry out the research actually, you take various combinations actually, but I'm just highlighting actually majorly the outcome of 2 groups. The group which is not active with the bioactive molecule, but the group which is with the bioactive molecule, and it is with the hydroxyapatite and PTMC. PTMC, which I mentioned, was a synthetic material. So you have a better outcome actually with the one which is having both BMP and ZA. So this was in the tibia, critical size of tibia defect actually, which is about 1 centimeter even defect actually you can create. In the rat model, which can be filled in with that. So, but the other, which was on the rabbit cranial part, you can have 4 defects created on the cranial part in the rabbit. You have the MPT, you have then you have PTMC, and then you have PTMC hydroxyapatite with both bioactive molecules. Again, different number of groups are there, but I'm just showing the outcome of just 2 groups. But we also varied here basically the other calcium salt hydroxyapatite, and then in another case we added tricalcium phosphate. Both of these, hydroxyapatite and tricalcium phosphate, are typically being used in bone regeneration, but in various combinations. Again, I'm not going in detail with the histology part, but yes, again in the case of that group which is having both BMP and ZA, you got a recovery within a period of 4 months. Whereas in other, the recovery was there as compared to the just the sham. You have the recovery, but still the recovery was not as fast as in the case of BMP and ZA. So the second part, actually, which has been of interest to us for a now long time, actually, has been how by these materials, actually, we can deliver antibiotics and some other type of drugs, actually. But initially, we started actually with the antibiotics, actually, because finally, even commercially, if you sell them commercially, actually, or used actually in the clinics, you will still need to have actually some antibiotics, put on that. Very interesting, which I'm not going to discuss here. Very interesting phenomena which was observed actually with both calcium phosphate, calcium sulfate, and hydroxyapatite was that it nicely can bind to many of antibiotics. Mostly ionic interactions has happened actually. Hydrogen bonding was also seen in that actually. But we were majorly interested actually with rifampicin, because that was our interest actually to develop an approach for bone tuberculosis, actually, particularly spine tuberculosis, actually. Before I go into that, actually, let me give a little bit of, I understand all of you are able to knowing that actually what are the complications actually of infection in the bone. Like, for example, chronic osteomyelitis, actually, that can have muscle atrophy, reduced movement in the joints, bone necrosis, fistula. Spine tuberculosis, actually, particularly the Indian condition, actually, it is becoming very, very serious condition, actually. But other extrapulmonary tuberculosis in the bone are being seen, but spine becomes actually one of the most complex. And treatment strategies are also not so successful because the distribution, that distribution of antibiotic distribution has not been so effective in the spinal tuberculosis. So you get spinal cord compression, kyphosis, and obligation in vertebra. You can have the conditions like that. You have the osteomyelitis infections like that. You have joint infections, or you can have succustium. Right now, present treatment strategies is medical therapy. You give the conventional drugs, which can be oral or it can be intravenous, antibiotics only, or you can have administration of antibiotics intravenously. Surgical treatments, actually, you clean, make the debridement, decompression, or posterior anterosis. These are typically what are being used actually in tackling the infection in the bone at several conditions. Actually, limitations is overall the outcome has been very, very poor actually in all of these conditions. Actually, typically in bone tuberculosis. Has very, very be limited in that type of situation, actually. But that means there has to be something actually which has to be done locally. You have to treat the infection at the local site so that you can have a sort of exposure of the drug minimally but effectively, actually, rather than distribution actually throughout the body. So we took the first example of rat tibia infection actually with osteomyelitis actually. So which we did with S. aureus, infected for 20 days in rat tibia. Then, of course, after infecting, we close it back and then opened it actually, because 20 days you cannot keep it open when you have given infection in the bone. You have to close it, but then you open it again at that site. You make the debridement, which is typically done clinically, remove that, and then at the infection site, now you implant your matrix. Typically, it is the cement here, which is containing actually the rifampicin. You can use another antibiotic actually, but as I said, actually, our interest was to go with the rifampicin. Actually, we had finally to go with the tuberculosis, but rifampicin is a broad spectrum antibiotic. Actually, it can tackle other type of infections. S. aureus is not at all any problem in that. So in that, you will see that actually we have put it here, and then we have analyzed it after couple of weeks actually that we have completely seen. The 4 groups which you are seeing, where you have only debridement, where you have just removed that lesion, and you have oral.
Kumar, your slide is not visible.
This slide is not visible?
No, somehow I think there was some connectivity issue, and then when it resumed, your slide is not visible.
Just a second. I can see it my side here. I will upload it again.
Oh, please, yeah. Please.
Is it visible now?
No, no, no.
The slide is visible.
Slide is visible. You are able to see the slide?
Yes, yes, we can see the slide.
Professor
Oh, yeah.
Chattopadhyay is saying, Nabita, you are able to see? What about others?
Yeah, we can see the slide.
Go ahead, go ahead.
Okay, maybe Professor Navodaya, maybe you have some connection
No,
issue
no,
on.
go ahead, go ahead. It is visible. Go ahead, please.
Okay. So what I was discussing here actually that these four groups is typically, I mean, what we all know actually, you have one group which is not having any treatment, another group which is perhaps having the oral treatment actually, the third group which is having the cement only actually, but no treatment locally, and the fourth group basically is having actually a treatment locally given with the cement along with the rifampicin. Very clear-cut difference actually. I am not discussing this part, microcytia impact actually, but here you can see the clear actually that you have complete bone formation actually in the fourth group as compared to what the other groups are having. So you eradicate, it was not a question of just only simply eradicating the infection actually. You may eradicate the infection actually, but when you have actually such conditions actually, typically when you have actually the infection or you have the osteosarcoma actually, the tumor in the bone, there is a lot of loss of bone. That means you have to actually have also a bone formation at that part. Besides, of course, treating the condition, disease condition. So both bone formation as well as infection actually was controlled. This was one of the rat tibia model here. If I just look into actually if there was any type of bacterial count, in the fourth one, which is treated locally with rifampicin, you cannot see anything. Actually, it's a sort of baseline here. But in others, you may see a little bit actually where oral is given or locally RFP is given actually and NC is given. But when there is nothing given, actually, you will see a lot of blood, bacterial count in that. Same with respect to the bone formation, you will see maximum bone is this is mesenteric actually. You will see the maximum bone formation actually in the fourth group. So we again extended this into the condule model. Which is again, I mean, we are mainly tackling actually those typical conditions which are clinically there because it has to become very relevant actually what tomorrow actually you have to have a solution. So condule is another part where you commonly get the infection. Actually, it can be the knee replacement. Actually, it can be the joints. Actually, where you have the problems. Actually, but in that case, we made a composite of both, polymer, which can be a sort of gelatin or we can be collagen actually, and the ceramic material actually. In that case, you have collagen. Then you have in gelatin also, and then you have nanohydroxyapatite, and you have rifampicin there. And you make a composite by freezing condition, actually, which is our indigenous technology, what we call as cryogelation technology, and you make a scaffold like what you see it here, which is embedded with rifampicin inside. Because this exactly mimics actually how our bone is, which is containing collagen actually and containing hydroxyapatite. So now it is already having the rifampicin there. Now it's a question actually to again, this is just the characterization of. I will not again go into the detail of this, but in this case we took basically the two organisms. We took the Mycobacteria smegmatis and we took the Staphylococcus aureus and try to see actually what is the effect on both of them. It is very evident that smegmatis, it works much better. You will get actually have a sort of much zone here as compared to what you will see actually in the case of S. aureus, but it eradicates also infection in the S. aureus. But smegmatis is what the rifampicin typically will have actually, better in. So, but this was just in vitro analysis. But obviously you can have it. Now you develop a sort of femur condule model, which I mentioned to you. See, purpose was not only to just eradicate infection here. Purpose is after the condule has been eradicated, has been also excised actually with the bone, can I get actually bone formation back in that? Can I get eradication of the infection actually? Again, this data actually is presenting the same with the two organisms which I mentioned as smegmatis and smegmatis and S. aureus. So you have again in both of them again bone formation in the last case where you have BMP and ZA. you will get actually the best outcome in that one actually. This is just the histology again showing the same, that the outcome in with the bioactive molecules is higher. One of the interesting, project which we took, which I want to correlate with many of your thoughts actually, is people who get osteoporosis. They have, which I described actually between the men and the women, actually the chances of getting hip fracture actually is very high. Women are much more than the men. But whatever is the situation actually, when a patient actually with osteoporosis comes with a hip fracture, obviously, orthopedic surgeon actually will treat the fracture actually in the femur head, femur canal, which because that's the hip fracture typically is there. But it is, very common. The same person after maybe 4 months or 6 months actually comes back with a fracture in another hip. The reason for that is, the load is completely shifting to the other part. The osteoporosis is increasing. You have no prevention for that. Actually, it also becomes actually more fragile, the hip. And if the load is shifting to the other part, actually, you have more chances of getting actually the fracture in the contralateral hip also. Actually, we gave a very interesting thought in that. Can there be an approach where the patient coming actually to the clinic is being treated for the fracture in the hip, femoral head in the hip actually, which are osteoporotic? Can we also have a sort of preventive measure at that point of time? So what is that measure? As such actually, if you ask a patient who has osteoporosis actually, and tell him that, okay, come to the hospital, we will just inject some material actually with some sort of bisphosphonates actually, I think nobody is going to be ready for that. But when the patient is already there in the clinic, so while a clinician is treating actually the fracture part, because we discussed this actually with the orthopedic surgeons, actually, whether this is possible. This is a concept actually, but whether it is feasible finally clinically. Of course, they said obviously we still have to take a consent from the patient, but since this surgery takes a long time, they are admitted there actually for a long period of time, we can inject actually the material in the another hip. Because it is minimally invasive, patients will not have any concern. We did in fact that. We created actually osteoporotic rats, made a fracture in one hip, we treated that hip, and simultaneously for preventive measures actually injected actually the material in another hip and measured whatever the parameters are there. So I'm just giving actually the sort of background of this particular project actually. So this was something actually which was conceptually very interesting actually, which now in fact has gone to the clinical trial as well. So it's being pursued actually in Slovenia actually, this work for the clinical trial with the same concept actually, that we can give a sort of preventive measure actually on the another hip. I'm not going to, just again mention a lot of things actually related. What are the current strategies? Current strategies is very, very, standard. You give several types of drugs actually, which includes even, you have actually estrogen receptors actually. You have estrogen, progesterone therapy actually. You have some antibodies actually. You have PTH actually, or you have simply bisphosphonates actually. That's a standard type of use. Of course, actually, till there is not a fracture actually, you still take that. Challenges, of course, actually is that you have fracture healing as a major challenge. Local delivery is something actually which is addressing this type of problem actually. So as I said, actually what we did is actually that we just took exosomes. Again, the exosomes is not a problem. You can take it from the patient actually. Even in the patient, you may not have to isolate the exosomes. You take the bone marrow directly and simply put it together this. Then we made actually the material out of that. And in the femoral head, we created the osteoporotic model. And then in both heads of the rat, in one we created a fracture and made a treatment. In another one, actually, we simply injected the material actually and left the animals actually as such, and see actually whether there's a preventive measure as well as treatment actually. This is a sort of, what you can see with the X-ray images and all actually. Of course, those with where we have given both BMP and ZA, you have actually the better outcome. both in the lateral leg as well as the one active which is fractured. Some statistical data is here, which again is presenting the same, that we have a better outcome active with that. And within the contralateral part, actually, most important was to see actually whether we get the mechanical property back. So, because that is something actually which you want to see in the cases of femoral head, whether the mechanical property is also coming normally to the same level. Actually, we measured into the both contralateral and defect area. More or less, both in the defect area as well as in the contralateral, actually, we have achieved more or less the same type of outcome, and which is also presented by the histological results. Actually, but most critical in these cases is the mechanical property of that. Actually, this was related to osteoporotic, which is hip fracture osteoporotic, actually, from preventive and from treatment strategy point of view. I will just describe the last maybe couple of minutes. I will take more. As I mentioned to you, actually, that we have been now for last 5 years looking into actually the alternative for metal implants, titanium or like stainless steel. Actually, what can be the possibility actually of that? Because as you understand, actually, if you have hard tissue repair, so you have long bone repair, you have joints and teeth, you typically use wires, pins, screws. You have fracture plates and intermediary devices. So then you have joint implants, actually, and you have also dental implants, actually. So the non-degradable materials, which is stainless steel or titanium alloys, actually, they are high in mechanical properties, no doubt in that, actually. But high in mechanical properties is not necessary to be a sort of major advantage, because it can have a sort of what you call as stress shielding over time. That means they will loosen, because mechanical property of the bone with these type of implants is not matching. You need a second surgery in that case, actually, because you have to take the implant, metal implant out. It is not degradable. So it's used as a prosthesis, actually. But degradable materials, on the other hand, like magnesium in its alloys, like iron, zinc, strontium, all these type of things are combined actually with the magnesium. Mechanical properties are close to the human cortical bone, which is good, because then you will not have stress shielding. Second surgery not required. Degraded metal particles are non-toxic, though of course it is not a sort of universal fact. Actually, it can be still being toxic. Actually, it is all how the alloying is being done. So, however, nothing comes with perfection. Actually, as I mentioned, also in the degradable things. Actually, one of the major limitation, actually, and that has been the reason actually why magnesium is still not there in the clinics in the orthopedic application. Actually, has been high degradation rate. An orthopedic surgeon would like to have at least an implant inside the body, minimum for 1 year, or even for 2 years, depending upon actually the type of defect. Okay, so that means the magnesium alloy, magnesium implant, which you put it there, should stay there for that much actually, and not lose actually the mechanical property actually. There is an issue related to hydrogen gas generation actually with the magnesium. Loss of mechanical integrity in between healing process. These have been major complications actually with magnesium, which has still not been addressed completely, even today. But a lot of has been, gone into this area. Even in India, actually, many groups are working in this domain actually, with the same focus that how actually these limitations can be overcome. So magnesium purity becomes one of the most important part there. Alloying process can be another thing actually, and also actually several modifications, maybe surface modification, and also how you can improve the corrosion resistance. Those are something actually which needs to be taken into consideration. We looked into one aspect actually, which I just want to mention actually. Making a magnesium alloy is not simple, because it's not any other type of metal. It needs an inert atmosphere. So having something to make an inert atmosphere is typically considered to be very critical, because you have complete inert atmosphere. Even if you have traces of oxygen there, it will catch fire. You will get oxidized magnesium actually. So that is the reason actually even groups worldwide, even India, rather than actually focusing on making the magnesium alloys, they are basically focusing on picking up the commercial magnesium which is there, but that's not meant for medical purposes. That is general magnesium actually, which is being used for various other purposes actually. They take it from the shelf and try to modify the surface. and see if you can actually improve actually the properties. To some extent, yes, but not completely. Actually, this becomes one of the major limitation. Actually, but we took a challenge actually to just make these furnaces, very specialized furnaces, custom designed furnaces actually to generate this type of magnesium alloy here at IIT Kanpur actually, and on small scale, I can say we have been able to generate actually these magnesium alloys and also have been able to purify this magnesium which we have been buying commercially by simply alloying process. So that actually if you have a high degree of purity of magnesium, actually corrosion rate, degradation rate can be controlled. So also alloying actually with other type of components, like we have been alloying it actually with HAP, hydroxyapatite, strontium HAP. I'm just giving a sort of glimpse of overall result which have come out after that. So cortical bone has the strength as tensile strength like this. You have Young's modulus and you have compressive strength like this. And when we have magnesium, which is a pure magnesium, what we have actually, alloyed a couple of times, that means we put in the furnace one time, take it out, put it again in the furnace. So you purify, you remove the impurities from that. So you brought actually the tensile strength actually, not to that close, which is a cortical actually, but at least, you can have actually that strength. Tensile is not that critical as compressive strength is or Young's modulus is. So compressive and Young's modulus is coming close to what actually should be the case with the cortical bone here. So purifying magnesium and then putting these alloying elements like the hydroxyapatite or strontium hydroxyapatite actually has improved the corrosion properties actually and also has improved actually the degradation properties. This is the data actually what you are seeing it here. Obviously, actually, the black one, what is showing the bar here, is just simply the magnesium, actually, which is just simply corrosion, which has a corrosion, actually. But when you are having actually magnesium HAP or magnesium strontium HAP, you have decreased this corrosion rate significantly. Hydrogen evaluation rate also has decreased significantly. And after that, we took this material actually for surgical application actually in a rat model actually, and try to see actually, of course, in vitro we are seeing actually some positive outcome, but we wanted to see actually what is happening actually in the rat. So we kept in the rat for 3 months, and we saw actually the material is not losing any type of property in that. But we are now continuing with this material actually on higher animals. Actually, if we can stay for 1 year with not losing the mechanical property, I believe this is something actually which can be very, very useful actually for orthopedic applications actually. So, we recently transferred a technology actually to orthoregenics actually, which was on one of the, I think the projects I discussed actually. In fact, it's a positive outcome actually that even CDCSO have felt that since the results are promising actually and it's comparable actually, which is with the international product. India does not as of now make any type of bone substitutes actually, which is ceramic based. Methacrylate based bone substitutes are there. But this is the first of its kind actually to be just launched actually if it gets successful actually. Of course, we are looking into the clinical trial, but we are discussing also actually with the drug authority actually if they compare actually with the market survey actually. One product of ceramic is in India, which is European product, which is matching with the results of that. So, and these are some research publications which has come out from that. The funding agencies which I would like to acknowledge. On various areas, but I would specifically like to mention my research collaborators actually Lars Lidgren, Professor Magnus Tagel, Jukka Spola, and Professor Juni Parton from Aalto University and Lund University. They have been very closely working with us actually on bone area. Other collaborators are on other type of tissue engineering aspects actually. So thanks to my group who has been working on this actually. Thanks a lot. Any question? Most welcome. I have taken a little more time actually, but I hope it should be fine with any question which you have.
Yes, definitely. You had it was very lucid presentation. Given significant time to build up on what you are going to do on. One interesting thing that really caught my attention you said about is periosteal regeneration. Indeed, periosteum is particularly after this kind of a fracture, periosteum plays the most critical role, because not only the lining cells, which can become osteoprogenitor upon growth factor stimulation, but below the periosteum lies mesenchymal stem cells. That is a region for supplying mesenchymal stem cell after any fracture. So in terms of periosteal regeneration, what kind of studies are you doing?
In fact, actually, I had a few slides because I had, but I skipped them actually because I thought it will take longer time actually. We use a membrane technology for periosteum, but for bone, typically we are making actually the same bone substitutes actually, but for periosteum, we do typically have a sort of membrane which we have impregnated actually with some antioxidant. We have also actually put oxygen releasing properties in that, and we are supplying actually with the exosomes actually, but it's a thin layer actually, which you have to cover actually with that. See, of course, periosteum in most of the cases, if the defect is not so large, so it is what you call it actually, as you are also aware actually, it's called the bridging, the corners actually in the bone. When the bone bridging happens, the periosteum also starts actually growing in that manner actually. But if that becomes a sort of limitation actually, you get the trabecular bone, you get some part of cortical bone actually growth actually, but then the upper part actually is not completely, you don't actually have the bridging of the bone on the top. So then the periosteum actually becomes the limited part actually. We put this membrane, especially for periosteum actually, with, as I said, actually with the antioxidant properties. Actually, we have a polyurethane membrane, which is a little bit stretchable, degradable polyurethane membrane. It's containing antioxidant actually. We can of course have some sort of some growth factors also in that actually, but what we have at the moment done actually only put the exosomes in that, and we have put some antioxidants. And I think I have. Just give me a second on that. It is good that at least I have the slide here actually. So this is exactly what you have been discussing actually. That is the periosteum part. You have the cancellous part, and then you have the cortical part beneath this actually. So, but for this part, that is the periosteum actually, along with the cortical part, we are developing this bilayered periosteum actually, which is mimicking basically the same structure actually, but the inner part, which is the cancellous part, is the same composite which I have been discussing actually. But you incorporate some bioactive molecules on that, growth factors in that. So we did do it actually by electrospinning. This is on the right side actually of this. And you have this electrospinning procedure actually, you put it on that. So if you wrap this around this, you make it almost as a sort of synthetic periosteum actually, and put it at the defect area actually, where the defect area is. So then the connectivity of the edges becomes more. So this is the second slide actually, which we have drilled a large bone defect actually, where the periosteum was stripped off and then put basically the material along actually with this. You see this wrap on the model here. So we have put this wrap around this. But interesting part I can see actually, which is more easy to understand, why we did not do that. We did not got the markers, but where we did detect, you get the periosteum marker actually, which is green in all the conditions. You can see it here, RP311, just in that tissue. But this was missing when you did not put basically, this one. We had another case, actually, as I said, periosteum, we did a lot actually on that. We had osteosarcoma. In osteosarcoma, it becomes a major complication, periosteum generation. It's one of the major issues because you lose a large amount of bone in the osteosarcoma. You may get a bone formation actually, but then it again remains actually quite weak. In that, we just took some, some components actually, which are herbal components, which I have mentioned once to you actually, like cichus. We see very interesting property on cichus to aid in periosteum. So now we just simply put an extract of cichus on this part and look into actually the possibility of regenerating actually the periosteum in that. Actually. We can discuss on that maybe specifically. I know actually you have interest on that part related to the. It's a very interesting. The issue is actually on periosteum. It is always a neglected from bone material point of view. Actually, basic biology do a lot of work.
If anybody has any questions, please feel free to ask.
Good afternoon, Dr. Ashok.
Good afternoon. Good afternoon.
Yeah, this is Dr. Deepa Ghosh from Institute of Nanoscience and Technology.
Thank you very much. Thank you, madam. Thank you meeting you.
We have met a long time back in Reliance, so I hope you remember me.
Oh, I now remember. So you have moved from Reliance to nanotechnology.
Nanoscience, yes.
You remember I came with a delegation.
Yes.
But that was a different, altogether a different thing. Actually, yes. Very nice to see you here. Actually, I still can understand. Actually, you still will be having interest actually in this area. That time, I think we were discussing more on cartilage.
Yes.
Yes. Yeah, madam, please.
Yes. So yeah, very nice talk, and a lot of work has been done. I'm just curious about your the study where you are talking about osteoporosis and how you have given exosomes to the other part of the undamaged hip joint. So what does it do actually, these exosomes? Are you expecting it to improve the bone structure, or what exactly does it in what way does it help?
Very interesting question, actually. But I think, of course, I mean, as we understand it, and these were exosomes, by the way, from MSCs, bone marrow derived MSCs. Of course, it can be also active from the bone cells. Exosomes actually, as you see, actually dumping, bodies, they do carry actually a lot of microRNA actually, and some growth factors, actually, which are both anabolic and anti-catabolic. Actually, no one so far actually, if I am not completely updated actually, but at least to my knowledge, I have not. But maybe Professor Chattopadhyay will, correct me actually if that is correct. We have been looking into actually the components in that exosomes actually what are responsible basically on anabolic function actually in the bone growth. Vis-a-vis if it has also anti-catabolic activity actually. That is going on actually. We have not yet received actually the result, but we have carried before this osteoporotic model. We have simply carried actually in other models actually, which is simply a tibia defect. And when we have actually, kept the exosomes there from MSCs, we see actually that there is a increase in the bone growth. There is mineralization has improved actually, bone volume has increased versus the total volume actually, mechanical strength has increased in that actually. So we are at the moment actually thinking that there are obviously the anabolic agents there actually which are helping in that. So but what perhaps is your question on related to the osteoporotic model, we started that with first BMP, because BMP obviously is a standard thing. So we have a work related to the BMP also in that. There's a patient actually which is having osteoporosis. So both the hips have actually the same degree of osteoporosis actually, but one hip got fractured. So he has to come to the hospital and get this fractured hip repaired. The treatment strategy of that fractured hip is different. Obviously, they have to put some sort of implant and all, actually, along with the ceramic material, actually, with these BMP, ZA, or maybe exosomes, actually. But while treating that hip, which is having actually the fracture, we also try to see actually that we just give a preventive measure to the contralateral hip. Non-invasive, minimally invasive actually. It is just by injection actually. Orthopedic surgeons actually from outside can reach to the canal easily. There's no problem actually. They don't have actually to open it. They simply can reach by the needle and can put the drug there. But the drug obviously has to stay there. So the drug now in this case was exosome, but I told you actually why we used the BMP. BMP was the standard approach, BMP and ZA. With BMP and ZA, actually, obviously the efficacy was very, very high. But then in this particular case, which I mentioned here, we used the exosomes. The mechanism of exosomes, as I mentioned, is mostly that we feel actually that it acts as an anabolic, gives mineralization there, and it also has some anti-catabolic activity, which we have shown in another studies. But whether we have identified those molecules in exosomes, we have not done that. Actually, we have in that process. I hope I make your question clear.
So it looks like if this is working, then it can be used as a preventive measure for those geriatric patients who are susceptible to hip fracture. Is that
Absolutely.
what?
Absolutely, that is the idea, actually. But as I mentioned that actually when I was discussing that actually, as such, I mean, even if people are having osteoporosis, actually, they have high level of, and they are bound to get hip fractures. They will not come to the clinic, actually, or you cannot make them to come to the clinic actually before they actually get the fracture. So it was that thought. In fact, actually, this was discussed among with the surgeons and all. So they said nobody can come, even like in the European countries, actually, where you have this condition, actually, maximum. So even in those, actually, they have this same strategy of preventive, actually. They only can give orally, that's fine, but they cannot ask them that, okay, we inject actually something in your hip. It's the acceptance is not so much. But yes, when they are already in the clinic, they are already there, as patients. That time, probably they do agree. And as I said, actually, this is now in the clinical trial already going on. Acceptability of the patients is very high in that.
Okay, thank you.
Okay, thank you very much, Dr. Kumar, for giving us the time and explaining your talk. We are really thankful to you, and we will soon circulate this video of this presentation to your group. Basically, we circulate it among the people who are attending this Bhasti webinar. At the same time, it is also my request to you is to let us know any young investigator whose work you think is exciting and meritorious enough so that I can make a separate invitation for webinar.
Sure, sure. I mean, of course, I know in the area, actually, so I can give you some names here.
Sure, please.
Thank you so much. Thank you so
sir.
much. Thanks for
Bye.
everyone there. Bye. Thanks.